Today's webinar, Report Back from SGO, What's the Latest in Ovarian Cancer? I'm Maggie Nicholas-Alexander, the Senior Director of Gynecologic Cancer, Patient Support, and Education at SHARE. Today's webinar will focus on any new information and research advances from the Society of Gynecologic Oncology annual meeting held in March. Before the presentation begins, I'd like to tell you a little bit about SHARE. SHARE is a national nonprofit that supports, educates, and empowers anyone diagnosed with breast or gynecologic cancer and provides outreach to the general public about signs and symptoms. Because no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information about our upcoming webinars, support groups, and helplines, please visit our website at sharecancersupport.org. This webinar is being put on in partnership with the National Ovarian Cancer Coalition. Since 1991, the NOCC has provided support to thousands of cancer survivors, delivered millions of educational resources, and connected with countless local community partners to raise awareness about ovarian cancer. You can learn more about all that they offer on their website at ovarian.org. Now I'm going to go over some housekeeping items. All participants will be muted during the presentation. Once Dr. Pereira finishes presenting, we'll begin the Q&A discussion. Feel free to ask questions through the Q&A section at the bottom of your screen. Remember that Dr. Pereira cannot give specific medical advice, so please keep your questions general. We also have closed captioning available. You can enable this feature by clicking the live transcript button at the bottom of the screen and selecting the subtitle option. This webinar is being recorded and will be available on the SHARE website soon. We're very excited to have Dr. Pereira joining us as today's speaker. Thank you so much for being here, and now I'll hand it over to you, Dr. Pereira, to introduce yourself.
Hi, I'm Dr. Pereira. I'm a GYN oncologist at Lenox Hill Hospital located in Manhattan, New York. I've been practicing there for close to 7 years. It's kind of hard to believe. Time goes by so quickly. I did most of my training in New York City. I have an interest in doing research. Most of my research is in cervical cancer, but we also have open phase 1 trials in our practice for ovarian cancers as well. I'm very excited to be here. Thank you for having me. And I guess we'll begin the presentation.
Sounds good. Thank you.
Go ahead and share. So today we will be talking about what's the latest in ovarian cancer, a report back from SGO. I think it's important to see kind of how far we've come in order to understand where we're going when it comes to the treatment of ovarian cancer. And so as many of you know, ovarian and fallopian tube cancers are the second most common GYN malignancy, with an incidence of about 26,000 patients annually in the US, affecting 1 in 70 women. And most of these are epithelial ovarian cancers, which make up 90% of the malignant ovarian tumors. Management throughout is typically consisting of a combination of surgery and chemotherapy with or without targeted treatments. And we'll talk a little bit about how those targeted treatments are kind of such a new part of how we manage these ovarian cancers. And so the combination of carboplatin and paclitaxel is currently the standard backbone of treatment, and none of that has changed even with the new data that came out of SGO this year. This is because 70% of women with advanced ovarian cancer will achieve a complete clinical remission after initial surgery and platinum-based chemotherapy. And so this combination is both effective and has a generally manageable toxicity profile. For patients with certain inherited mutations, targeted therapies such as PARP inhibitors can significantly improve outcome, and we'll talk a little bit about those as well. And so I just want to spend a few minutes on the basic science of chemotherapy. I think it's important to understand how chemotherapy works in order to fully appreciate what it means or what makes the newer therapies more targeted. And so the cell cycle is represented here. The circle represents the active part of the cell cycle. So the part of the cell cycle that's involved in cell growth and division. G0, which is kind of popped out to the side of that circle, represents when cells are at rest, when they're not dividing, when they're not growing. And so rapidly dividing cells, such as cancer, are constantly in the active phase of the cell cycle. And chemotherapy works by targeting different aspects of this cell cycle. The idea is that cancer cells are more sensitive to chemotherapy than the normal cells. And since our bodies also have normal cells in the active phase, such as hair and bone marrow, this can lead to the off-target side effects that we're all familiar with for chemotherapy. And chemotherapy is all we had for a really long time. It wasn't until 2011 that we started adding more targeted therapies to the carbotaxol backbone. And this slide is kind of busy on purpose because I think it nicely highlights just how many studies and how many FDA approvals occurred over that subsequent decade. And if you zoom in on the different trials, you'll see that all of these are either a PARP inhibitor or bevacizumab. And so I thought we should talk about exactly what makes those two drug classes targeted just over the next two slides. And so bevacizumab essentially binds to the circulating VEGF, which interferes with the endothelial cell proliferation and blocks new blood vessel formation. So generally, fast-growing tumors will quickly outgrow their blood supply. So they have a mechanism for upregulating the way that they can recruit new blood vessels so that they can continue to grow. Essentially, bevacizumab blocks the ability for tumors to make new blood vessels, and so it slows or stops tumor growth in that way. Because the tumor cells specifically have these receptors increased or upregulated, the treatment specifically targets the cancer cells, leading to fewer off-target side effects than you would typically see, for example, in chemotherapy. PARP inhibitors are another interesting targeted therapy. For some patients, as many of you know, I'm sure, ovarian cancer is driven by certain gene mutations commonly referred to as either BRCA or HRD mutations. Basically, cells have several ways of repairing the mistakes that can be made during cell division. Cancer cells with the BRCA mutation are missing one of these mechanisms, so they rely on the PARP pathway for DNA repair. If you block PARP, those cells cannot repair the DNA mistakes, and this triggers a signal for the cell to die. This is a targeted treatment because the normal cells, the non-cancer cells in the body, still have working BRCA. So if you block PARP in those cells, they have the other repair mechanism. And so those cells won't die, and it focuses, it targets really just the cancer cells specifically. Before we dive into what's new from SGO, I think it's important for us to kind of review and understand how GYN oncologists look at these studies and how we determine which new treatments can be beneficial to our patients. There are a few different ways that we define success in a clinical trial. Progression-free survival is the most common primary outcome in phase 3 trials. The definition of progression-free survival is time from completion of treatment to recurrence. And this can be expressed in months as median progression-free survival, meaning the time it takes 50% of patients to recur, or as a percentage of patients who have not recurred at a specific time point. And so some trials, for example, will report their progression-free survival at 3 years. They have enough data and they want to get it out there. And so they'll report the percentage of patients who recur at 3 years in each arm, rather than waiting for 50% of patients to recur. Overall survival, the definition is similar, but instead of time from completion of treatment to recurrence, it's time from completion of treatment to death from disease. And this can, again, be expressed in months as median overall survival or as a percentage of patients at a specific time point. Hazard ratio is another really important endpoint. It's expressed as a decimal and gives an indication of how much better or worse the experimental arm is. I think out of all of the different outcome data, in many ways, this one's the most helpful. So for example, a hazard ratio of 0.6 means that patients on the experimental drug are 40% less likely to have their cancer return. And an HR of 1.4 would mean that a patient on the experimental drug is 40% more likely to have their cancer return with the experimental drug. And kind of all of the trials that we review, especially when we look more closely at the trials that were reported at SGO this year, you'll see a combination of these different outcomes reported when comparing the experimental drugs to the standard treatment. And so very briefly, going to spend some time on this is really kind of a zoom in on that busy slide that I showed you a few slides ago. This slide highlights the outcome advantage seen with adding targeted therapies to the carbotaxol arm. And so all of these trials just added targeted therapy to the carboplatin paclitaxel regimen that continues to be the standard of care. And so the PRIMA and SOLO trials are two PARP inhibitor trials. And I just wanted to really show this slide because the progression-free survival advantage with the addition of PARP inhibitors to chemotherapy is so profound. In some trials, you gain up to a year, and in some trials, almost 2 years of a progression-free survival advantage by adding a PARP inhibitor to patients with the BRCA mutation. Earlier trials looked at adding bevacizumab to carbotaxol and showed approximately a 4-month progression-free survival advantage to adding Avastin. The GOG 218 was done in the US, ICON 7 was done in Europe. Slightly different outcomes, but still shows improvement in progression-free survival. Treatment at time of recurrence, very similar regimens here. Again, we're looking at PARP inhibitor maintenance and bevacizumab maintenance when added to chemotherapy in the recurrent setting. So now for the main event. This year's meeting was held in San Diego, and there were several really exciting ovarian cancer trials discussed at the meeting this year. The first one is a maintenance study looking at the addition of another PARP inhibitor to the carbotaxol backbone. This is referred to as the Athena mono study. And we'll talk about why it's called the mono study in a second. But essentially, patients with newly diagnosed stage 3 and 4 ovarian cancer were included. This was in the frontline setting, so patients were included if they completed the platinum doublet, so that carboplatin and paclitaxel, and had surgery. And they had to have demonstrated a complete response and that they were sensitive to the chemotherapy. As is often the case with the design of these trials, patients had to have a good performance status and no prior lines of treatment, because again, this was frontline. This trial is called a 4-arm study. Basically the mono part of the trial is looking at just 2 of the arms, and the combo trial is looking at the other 2 arms. And so what's interesting about this study is that the combo arm actually also includes an immunotherapy drug. Whether or not immunotherapy can be helpful in cases of ovarian cancer is still an area of ongoing research. And so the combo and the mono trials kind of happened at the same time. The results from the mono trial matured more quickly, and the combo data is not available yet. Hopefully that will come out soon, because we're all eager to find out if we can start using immunotherapy in ovarian cancer in similar ways that we've used it in our other GYN cancers. And so patients were randomized to receive either rucaparib or a placebo, and the maintenance treatment would continue for up to 24 months. What it means for it to be a maintenance trial is that patients get the upfront 6 cycles of the carbotaxol and then the rucaparib, the PARP inhibitor in this case, is continued for up to 2 years. This data was previously published. This is not what was presented at SGO this year, but of course I think it's important. So I'm going to spend a little bit of time on it. And so one of the ways that we look at progression-free survival in these trials is with a Kaplan-Meier curve. And so basically monitoring events over time. And as kind of a quick cheat, if the lines are so divergent that you can fit your thumb between them, that's usually a clinically and statistically significant difference. And so you can see the blue line, which is the rucaparib, and the red line, which is the placebo. Those lines are pretty far apart. And so at quick glance, you can see that the rucaparib has quite a benefit over placebo in preventing recurrence. That dotted line that goes straight across from 50, that represents that median progression-free survival that I mentioned earlier. And you can see that at 36 months, so at 3 years, the rucaparib arm had not even met that median progression-free survival, meaning that fewer than 50% of patients recurred at 3 years. Those are amazing results. The hazard ratio, you can see listed just below those numbers. The hazard ratio is 0.4. In this case, that means that if patients were on the rucaparib arm, they were 60% less likely to recur, for their cancer to recur. What's interesting about this PARP trial is that it included both BRCA positive and BRCA negative patients. And out of all of the trials that have done this, I think this showed the most positive results in the BRCA negative arm. So basically showing rucaparib can be of benefit to patients who don't have one of those mutations. The BRCA negative data is on the bottom part of this graph. And you can see a hazard ratio of 0.58, so about 0.6. And so patients, even if they were BRCA negative, were 40% less likely to have recurrence of their disease if they were in the experimental arm. So these are really, really important results and very great data. And so what was presented at SGO this year was the more long-term follow-up. And so like I mentioned earlier in the talk, the primary endpoint in a lot of these studies is progression-free survival, but there are other endpoints that are also quite meaningful. And so the follow-up, the long-term follow-up data that was presented was the time to first subsequent therapy and the progression-free survival 2, the PFS2. PFS2 is basically for patients who recur, who then go on a subsequent chemotherapy regimen. How long is their second progression-free survival? And then another one of the endpoints, in this case, a secondary endpoint, they also reported on overall survival this year. And so the first slide looks at the time to first subsequent treatment. And I think the results from this are a little bit intuitive. If it takes a patient longer to recur, I think it's intuitive that it would take them longer to go on another chemotherapy regimen. And so I didn't find these results to be too surprising, but it did show that patients who are on the PARP inhibitor had a longer interval between needing another chemotherapy regimen. The PFS2, so again, how long was the second progression-free survival after subsequent chemotherapy? This slide shows that there isn't much difference between the rucaparib and the placebo arm. And the reason that's important is because one of the questions we always ask ourselves when we're looking at new therapeutics is this drug going to somehow make the tumor or the cancer less responsive, less sensitive to the chemotherapies that we're already using? Will it create some resistance in the tumor? And so when you don't see a difference in the PFS2, it's basically showing that being on a PARP inhibitor doesn't create additional resistance to subsequent chemotherapy lines, kind of giving another metrics to say that this is a safe and effective treatment. They reported on overall survival. Overall survival always takes longer to mature. And so a lot of times overall survival will not be included in the initial publications. And so the overall survival was reported at the meeting this year. I think in general, GYN oncologists find overall survival to be a difficult endpoint to make sense of with ovarian cancer, especially when analyzing first line treatment, because patients, once they come off of a trial, they can receive any combination of regimens, surgeries. It's such a mixed bag that I think the overall survival gets a little bit diluted. And this trial did not show difference in overall survival, but how meaningful that is really, it's hard to say. Based on all of this data, rucaparib became approved for maintenance in the upfront setting for both patients with the BRCA mutation and without the BRCA mutation in Europe. That approval has not happened through the FDA yet, but I understand that it's being applied for. And so shifting gears a little bit to another clinical trial that I think is one of the more exciting things that has come on the scene in ovarian cancer treatment in the last few years. This is patient-reported outcome results from the phase 3 Mirasol trial looking at mirvetuximab soravtansine versus investigators' choice of chemotherapy in patients with folate receptor positive platinum-resistant ovarian cancer. What is mirvetuximab soravtansine, also referred to as MIRV, which is, I think, what I'll start calling it for the rest of this talk because the rest is kind of a mouthful. MIRV is an antibody drug conjugate that targets the folate receptor alpha. So these protein receptors live on normal cells, but in case of ovarian cancer, there is an upregulation, sort of an abundance of these folate receptors. Although ovarian cancer cells have a lot of these folate receptors, the folate receptor itself doesn't drive the cancer. So it by itself is not a target. So what they've done is create these antibody drug conjugates where they have designed an antibody that will interact with the folate receptor and then attached chemotherapy to it. So this ADC, this antibody drug conjugate, this ADC comes along, it attaches to the cell brings it inside, and then the chemotherapy can be released and target the cell directly. And so I think of all of the newer drug types, this is one of the most exciting. This trial and the next trial that I'm going to review are both this type of a drug activity. And so the Mirasol study, the results of like the outcome data was also previously reported. The data reported at SGO this year was just patient-reported outcomes, but I think, of course, the cancer-specific outcomes are also really important. So I'm going to spend some time presenting those too. And so just to discuss the trial design, again, we already discussed that this was for patients who had platinum-resistant disease. The definition of platinum-resistant disease is a progression-free survival of less than 6 months. The folate receptor alpha had to be detected on pathology with special stains and had to be upregulated in over 75% of tumor cells. Only high-grade serous histology was included. And patients had to have received 1 to 3 prior lines of therapy. Prior bevacizumab and prior PARP inhibitors were allowed, and patients with BRCA mutations were also allowed. And so patients were randomized to either receive the treatment or receive investigators' choice of single-agent chemotherapy. I think out of the study design, this is probably the section that I have the biggest criticism of. I don't think it was really a fair fight for the MIRV to be compared to single agent chemotherapy, because in most cases, I think GYN oncologists would offer a combination of one of these chemotherapies with bevacizumab in the setting of platinum-resistant ovarian cancer. And I would have loved to see Avastin actually included in that other arm. That being said, the primary endpoint was progression-free survival, and secondary endpoints included overall response rates, overall survival, And then this primary pro analysis is patient-reported outcomes. They also looked at safety and tolerability. This is a new drug, so always looking to see if it's safe and how patients tolerate the treatment. Duration of response, DOR, is another really important outcome, especially in cases of treatment-resistant disease, because you don't only want to see if they respond, you want to see how long patients respond for if they respond. And then again, you see that PFS2 as another secondary endpoint. And so these were results that were previously reported. See this Kaplan-Meier curve, which becomes pretty familiar after you look at enough of these trials. And so this top left graph is looking at progression-free survival as a primary endpoint. And you can see that the hazard ratio is 0.65. So the MIRV group was 35% less likely to progress on treatment than the chemotherapy arm. Interestingly, this bottom left graph looks at overall survival. And I had mentioned during the discussion of an earlier trial that overall survival difference is really hard to show in ovarian cancer. But you can see here that there is an overall survival advantage to treating with MIRV over chemotherapy with a hazard ratio of 0.67. So both of those are really exciting results. The secondary endpoint, the objective response rate, you can see that the rate is significantly higher in the MIRV group with 42.3% of patients responding. And the overall response rates include complete responses, partial responses, and stable disease. And so that's versus basically 16% in the chemotherapy arm. And that represents a difference of 26.4%. Safety findings, fewer patients had a grade 3 or greater adverse events in the MIRV arm, and fewer patients had to discontinue treatment because of adverse events in the MIRV arm. And so showing really positive cancer-related outcomes and improved safety and tolerability over chemotherapy. It's important to remember at the point of platinum resistant, many of these patients have seen several lines of chemotherapy, and in those such cases can be more sensitive to the toxicities of chemotherapy. So having an alternate treatment is very beneficial. This is the slide looking at patient-reported outcomes. They used this PRO assessment tool, which mainly evaluates abdominal and GI symptoms, looking at things like abdominal pain, bloating, patients reporting that their clothes feels too tight. So again, abdominal distension, bloating, bowel habits, gas, and feeling too quickly after eating, early satiety. And so they looked at patient-reported outcomes at several different time points. Initially, they reported the patient-reported outcomes between week 8 and 9. And you can see at this time point, there really isn't a meaningful difference between the two treatment arms. But when you look at sustained improvements, like how did patients do at subsequent time points at 15 weeks, at 24 weeks, the symptom improvement was more sustained in the MIRV arm than in the chemotherapy arm. So another sort of positive result from this trial. And so the conclusions are that patients treated with MIRV are more likely to maintain or improve an ovarian cancer-specific measure of quality of life improvements than the patients given chemotherapy. And MIRV demonstrated a statistically and clinically significant improvement in progression-free survival, overall response rates, overall survival when compared to investigator choice chemotherapy. So all really exciting results. And of course, the authors of the trial concluded that this should be a new standard of care for patients with folate receptor alpha positive platinum-resistant ovarian cancer. And I think to some extent that statement is true. And since this has the potential of becoming a new standard of care, I thought it would be helpful to spend some time on the unique side effects associated with MIRV. And so I think one of the most unique and interesting of the side effects is eye toxicities. And these can actually be quite common, with up to 30% of patients reporting some kind of blurred vision or dry eye, sensitivity to light, eye pain, redness. Um, and because of that very specific outcome, it's actually a standard recommendation for patients to see an ophthalmologist who is trained in recognizing these side effects, seeing an ophthalmologist before treatment starts, and then every 2 cycles or like 8 weeks or so while on treatment. Pneumonitis, lung toxicity is another common side effect. Pneumonitis is an important one because it can be severe or life-threatening. And so it's really important to monitor for signs of trouble breathing, shortness of breath, cough, or chest pain, and of course to share those side effects with your doctor if you're on this medication and you start experiencing those things. Peripheral neuropathy, I think, is one of the more difficult side effects of this therapy because, as you know, a lot of patients who have already received carboplatin and paclitaxel will have some residual neuropathy from their treatments. And so being on MIRV can add to that. So again, very important to monitor for signs of worsening numbness, tingling, burning, and other neuropathy symptoms. The eye toxicities are so unique and so important that the drug manufacturer actually provides a lot of resources reminding patients when to take preventative eye drops. I think there's actually an app that will text your phone and remind you when to take the eye drops throughout the day, just that can try to minimize that side effect. And last but certainly not least is a phase 1 trial that I wanted to present to everybody, looking at RDXD monotherapy in patients with previously treated ovarian cancer. This is a phase 1 trial. So really the goal of a phase 1 trial is to look at safety and find appropriate dosing. But at the same time, you can also gather information about treatment response and efficacy of the drug. RDXD is another antibody drug conjugate, and it's comprised of a humanized antibody against a protein called CDH6, and the chemotherapy drug that's attached to it is topoisomerase inhibitor, which is a commonly used chemotherapy drug in many different types of cancers. And so the study design for this phase 1 trial, the part A is a dose escalation. So they basically start at a low dose and increase it until it's felt that they've reached the maximum tolerated dose. And then they'll do a dose expansion where they select the doses that they found from part A and look at additional patients in a part B to really test that those are the safest and the most appropriate doses. And so what safety data were they able to get from this phase 1 trial? The conclusion was generally that the drug is well tolerated. Most of the side effects are in the grade 1 to 2 category, so mild, manageable symptoms. You can see from the list on the right that most of the more significant symptoms are GI related, which of course can be tough, especially in platinum resistant patients. So nausea, vomiting, diarrhea, both sides of the spectrum. Constipation is there, decreased appetite, and then dehydration. I think that all goes with just a constellation of GI upset. The sort of category of side effects that I think were more likely to be grade 3 are the bone marrow toxicity, so anemia, neutropenia, the white counts being affected, and platelets being decreased. And so I think basically GI and bone marrow toxicity seem to be the most important of the ones that were reported at SGO this year. The preliminary results also gave us an idea of anti-tumor activity, and I think that this is a really exciting slide. The overall response rate, you can see confirmed overall response rate was 48.6%. And so typically when we're looking at results from a phase one trial to decide should it be moved on to phase two, we get excited if we see an overall response rate of 20 to 30%. And so a 50% response rate is really exciting. And this overall response rate of almost 50% included 1 complete response, 17 partial responses, 18 stable disease, and no patients that progressed. So that's really exciting. That translates to a disease control rate of about 97.4%. Another exciting endpoint with this trial was the median duration of response. So I mentioned earlier, overall response rate is important. But we also want to know how long patients respond for. And you can see this duration of response is close to a year. Median time to treatment, it takes patients a little bit less than 6 weeks to start responding to this therapy, and the median progression-free survival is 8.1 months. So all really exciting data for a phase one trial. And so conclusions are that, statement is that RDXD is the first CDH6 directed ADC to demonstrate promising efficacy in heavily pretreated patients with ovarian cancer. Efficacy does not seem to be dependent on the level of CDH6. So you might remember from the MERV trial, patients were only offered the treatment if they had high folate receptor levels, but the number of CDH6 receptors didn't seem to matter, which is also exciting because this could represent like a universally available option for patients. We talked about overall response rate was very promising, median duration of response, median progression-free survival. The toxicities appear to be manageable. And with a 50% overall response rate, this has been moved to the next phase, a phase 2/3 trial that has been initiated globally. I looked last evening at the cancer.gov clinical trials, and it looks like right now it's only open in Japan, but it has been assigned a GOG, the American Coalition. It's been assigned a number for the GOG, so I'm hopeful that this will be open in the US as well sometime soon. And so the clinical design for that phase 2/3 trial that's hopefully up and coming, patients will be included if they have high-grade serous or endometrioid ovarian cancer, 1 to 3 prior lines of treatment, which can include bevacizumab, platinum-resistant disease. These patients are required to have already received MERV. I think the MERV data was so promising that to get into the ethics of enrolling patients in clinical trials, the authors of this clinical trial likely felt that patients should be offered MERV before being offered a new therapeutic. And of course, they couldn't have had any prior lines of similar agents. And so the phase 2 trial will include the different doses again. And then from that additional dose finding phase, then they'll transition over to the phase 3 trial, which will compare the dose discovered from phase 2. It'll compare that to single agent gemcitabine, doxorubicin, topotecan, or paclitaxel, basically doctor's choice. And that's that. And so in summary, PARP inhibitors continue to show the most profound improvement in outcomes for patients with ovarian cancer, and this is most significantly in patients with a BRCA mutation. Bevacizumab remains an important targeted therapy, especially in the maintenance and in the platinum-resistant setting. MERV improves progression-free survival and overall survival when compared to single-agent chemotherapy in patients with platinum-resistant ovarian cancer. And RDXD demonstrates promising efficacy in heavily pretreated patients and is moving to phase 2/3 trial development. We continue to explore the potential role of immunotherapy in ovarian cancer, but still there really haven't been many positive trials showing that immunotherapy is effective for ovarian cancer. This is me and my partners at SGO this year. That's Dr. David West on the left. She practices at Northern Westchester Hospital, and Dr. Janine Villela is my partner here at Lenox Hill. Thank you so much for having me, and I would love to take any questions now.
Thank you so much, Dr. Pereira, for breaking down all of these findings in such an understandable way. So now let's start the Q&A. There were a lot of pre-submitted questions, but you can also still submit questions in the Q&A section at the bottom of your screen. We will try to get through as many questions as we can in the remaining time. All right, let's dive in. So not surprisingly, there are a lot of questions about MIRV. And one of them is, how long can patients stay on it?
MIRV. The trial included, let me just look back, because again, these are like new treatments. I actually have not had anybody on it for longer than a few months so far. Most of these trials in patients who have platinum-resistant disease, the recommendation for the treatment is to continue until progression or until toxicities. And so I don't know if that timeline has been necessarily defined, because of course it'll be different for all different patients.
Got it. And then this person specifically asking for the actual increase in overall survival in months for those on MIRV in the trial.
The actual increase in months. So to say increase in months, if you define it as like median progression-free survival, let me look back at I have a little graph here. It's teeny tiny. And so kind of hard to say it that way. And so when you want to see improvement in months, we can say at median progression-free survival, median overall survival, we can compare that. And so the median overall survival crosses 50% at around 12 months for the patients who are not on the drug, and around 18 months for the patients who are. And so it's about an 8-month overall survival advantage, just based on quickly looking at the graph. So very meaningful.
Very much so. And then we're also getting a lot of questions about clear cell ovarian cancer. And so I'm just wondering if there's any updates or any research in the pipeline that you could provide related to clear cell ovarian cancer.
Yeah, so I didn't see any positive studies out of SGO this year. I know there are many ongoing studies looking at sort of basket trials and things looking at specific mutations that affect clear cell, and whether or not we can use targeted therapies. But I'm not aware of anything that's been reported this year.
Thank you. And then we're getting questions about the length of time that patients can stay on bevacizumab after first-line treatment.
Yeah, that's a great question. So at first-line treatment, the defined amount of time is just what the trial showed. But I think in the recurrent setting is when we start using Avastin with sort of no endpoint in sight. And I think it goes back to what I said about MIRV, is that you can really continue it until progression of disease or until toxicities. And I have had patients on bevacizumab for years, and they tolerate it really well, and it keeps the tumor at bay. And I think that for me, that is the most important setting to use bevacizumab in, because it's generally well tolerated. Patients don't feel like they're on chemotherapy, and it ends up providing a very long interval, or can provide a long interval between chemotherapy regimens.
Thank you. And then going back to our DXD and that trial, this question is about how many prior lines of chemo were allowed And also, do you need to test for the CDH6, or how do you test for it if so?
So you don't. They actually, that was one of the really important statements from that initial phase 1 trial, was that they were seeing a positive effect whether or not patients had an overexpression of the CDH6. And I believe based on the study schema, at least for this phase 2/3 trial that is kind of slowly
Mhm,
opening, it was 1 to 3 lines of prior treatment, but I'll double check. Yeah, 1 to 3 lines.
mhm. Great, thank you. And then we were getting some questions also about low-grade serous ovarian cancer, and someone specifically asked about the results of the RAMP 201 trial. And then I also know that there's the phase 3 trial. I believe that's recruiting now. So I was wondering if you could talk a little bit about that.
Yeah, I'm not as familiar with those trials,
Mhm.
unfortunately, and I'm so sorry. If I had known ahead of time that these would have been questions, I would have probably dedicated some of the time from the talk today to discuss those.
That's okay. We're getting a lot of questions about some of the rarer tumor
They're
types.
rare. Might be worth doing a session on rare cancer types. Like,
We do, yes.
okay, coming soon.
Yes. And then we're getting questions uh, about how often or what's recommended for surveillance while on MIRV in terms of
Surveillance,
scans.
like chemo, like
Scans.
scans. Yeah. So how often to do scans is usually controversial, and becomes a little bit of like physician choice. And so in some cases, I will monitor symptoms in CA-125 and really not overscan patients as long as all of those metrics are looking good. And you get to know your patients a little bit. Like for
Hmm.
some patients, I know their CA-125 is really a great indicator of what's going on with their disease. For some patients, the C125 is not as great, and then I'll usually scan them like every 3 cycles or so.
Hmm.
But there isn't, if you look at the guidelines, there isn't a standard for like how you should do that.
That's why there's so many questions. Patients have so many questions about it because it's not uniform. And then some questions about PARP inhibitors as well. And we do get this question a lot, but can olaparib be taken for more than 2 years? And if so, are there benefits to that?
Yeah, so that question specifically has not been studied. And so the 2 years is based on how that initial trial was designed. Niraparib, just interestingly, the trial was for 3 years.
Mhm,
But what's interesting is when you look at the Kaplan-Meier curves, when you look at those progression-free survival curves, the effect of the Lynparza seems to continue even after treatment. And so I think that is a takeaway that most oncologists have gleaned from that data, long-term data, that there's no clear benefit to continuing it for longer. And then you worry
mhm,
about the toxicities and like kind of the scary toxicities of
mhm,
continuing it longer, like secondary malignancies and things like that, like
mhm.
leukemia.
And yeah, so that we also got a question about the risk of MDS and AML. So maybe you could talk a little bit about that.
Yeah, so overall the risk is still low. Most of the PARP inhibitors trials report a risk of like 1 to 3%. And so the risk is really low, but it's hard to say if that risk would increase incrementally if you continued beyond the time frame that was described in the studies.
Mhm. Great, thank you. And then we're getting questions about just looking whether another question about PARP inhibitors overall, but whether the side effects improve over time.
Yeah, that's a very interesting question. So It has been shown that the side effects from a PARP inhibitor are typically the most significant in the first months on treatment, which is kind of counterintuitive when you think about how patients respond to chemotherapy. Usually chemotherapy, it's like the toxicities build on themselves and they feel worse over time. But with PARP inhibitors, the fatigue and some of the quality of life affecting side effects tend to be worst at the beginning, in like the first month. But I usually try to convince patients to stick it out for the first like 1 to 3 months to see if after some time their symptoms will improve.
Mm-hmm. Great. And then we have a question about the use of estrogen blockers for ovarian cancer.
Yeah, and so there aren't great trials to support using estrogen blockers. I think by themselves, they are not very effective. I have definitely used estrogen blockade in some of the low-grade tumors, but
Mm-hmm.
in high-grade serous tumors, there isn't a lot of evidence to support using like aromatase inhibitors and
Mm-hmm.
the estrogen blocking tumors.
Could you talk a little bit more about it in terms of low grade?
Yeah, and so in low grade, we have actually found that patients can benefit from maintenance aromatase inhibitors. And so the standard of care is still to give chemotherapy, but now with maintenance estrogen receptor blockers, and the outcomes are improved that way.
Mm-hmm.
Most of us still don't feel comfortable giving up on chemotherapy altogether. And
Mm-hmm.
we don't have data to support doing that. And so it's
Mm-hmm.
more like addition rather than subtraction at this point.
Mm-hmm. Thank you. And then we got this question wondering if you know of any of these blood tests and whether they're widely used or effective in diagnosing ovarian cancer, like OVA Watch or OVA 1 Plus.
Yeah, and so what's interesting about those is that they all include CA-125. And so it's a little bit hard to flush out. Um, I think in the like general gynecology world, those have started to be used a lot more. But GYN oncologists still very much rely on CA-125. And then, you know, those are really used more in the like you don't there's no cancer there yet, and you're trying to decide if an ovarian cyst is something concerning or something benign. But
Mhm.
I think that the C125 and imaging studies are the most informative. And so none of my colleagues are really using those other studies currently. Sometimes I
Mhm.
get those results and then I look at the breakdown. I'm like, this is all from the C125. Like, I just don't
Okay.
think that those other things are very helpful.
All right. Interesting. Thank you. And then we're getting a sort of a follow up about whether you could explain again the progression-free survival figures, and or what progression-free survival means, which I think is really important for people to
Yeah. Because
understand.
it's the most important time point when we're looking at these trials. So progression-free survival is how you define the time from completion of treatment to cancer recurring. And progression-free survival can be described as a median progression-free survival. And that's really when we're trying to say how many months are gained by this treatment, the question that was asked earlier. Most of the time, you're talking about median progression-free survival because you want to see how long did it take 50% of patients to recur in one arm versus 50% of patients in the other arm.
Hmm.
Um, but median progression-free survival can also be described as a percentage. And so there are some trials where they're really excited about the outcomes and they want to get the results out quickly. So they'll say, okay, let's just describe what the progression-free survival was at 3 years. They don't wait for the median progression-free
Hmm.
survival to happen. They don't wait for 50% of patients to recur. And so then they'll say at 3 years, 20% of patients in the experimental arm versus 50% of patients in the placebo arm had recurred. And so then you look at the difference, and that difference is usually reported as a hazard ratio.
Hmm. Great. Thank you for explaining that again. And then we have a question about asking your thoughts on Signatera testing.
So I love this question because actually all of my fellowship research was in circulating tumor DNA. So I
Yeah, so
know
maybe you
from
could explain what that is and then
yeah,
share
so
your thoughts on it.
exact, yeah. So I think this is like where I get really
I
excited
can
because
tell
I think
you're
there's
excited.
so much potential here. And so we know that cancer is driven by gene mutations. And so the cancer cells will have a DNA profile that's different than the normal cells. And when cells die, they kind of like burst and release that DNA into the circulation. And so there's an opportunity to detect these fragments of DNA in the circulation, and this can serve as a tumor marker. What makes this a really interesting tumor marker is that it's very specific. If that mutation is there, that means the cancer has to be there. Whereas CA125 can be elevated. I've had CA125 elevated because the patient had pneumonia and had nothing to do with their cancer. Like CA125 is not specific. It can be elevated for other reasons. But if you see cancer-specific DNA fragments in the blood, you know the cancer has to be there. So it's specific. It also gets degraded very quickly. Circulating DNA can only survive in the blood for like 2 to 4 hours. And so you know in real time exactly whether or not the levels are detectable. Whereas C125 as a protein takes longer to degrade and can actually linger elevated for up to a month after it's not meaningful anymore. And so I think Signatera is really interesting. Signatera is basically a test where they take a sample of the tumor, they figure out which mutations are present in that tumor, and then they create a patient-specific blood test to try to sort of discover a patient-specific tumor marker, which can be very specific and sensitive. Um, the turnaround time from when the tumor is tested to when you can have a usable tumor marker, I think, is like 4 to 6 weeks. It hasn't been so. It's been shown that you can detect the tumor DNA in the circulation. What hasn't been really looked at, and I think they're collecting data now, is how to use that information. Um, is it prognostic? Is it being there on treatment? Does it matter? Like, how do we use this? Um, and there will, of course, be patients where the circulating DNA is never detectable, and it's just not a good tumor marker for them. Just same way C125 is not a good tumor marker for some patients. But I think it could potentially serve as a very sensitive and specific tumor marker for patients, better than C125.
That is exciting. And then we have a question about HIPEC and, if there's any updates on that.
Yeah, so there were no HIPEC updates at SGO this year, but I think that HIPEC is another really interesting opportunity. In our institution, we offer HIPEC in the interval debulking setting. And that's actually the only setting that the data supports using it in. By interval debulking, I mean those patients whose cancer is not resectable at the beginning. Those are the patients that will get chemotherapy up front, typically about 3 cycles, and then they go for their debulking surgery. At the time of that debulking surgery, there is a significant benefit to giving HIPEC, at least based on 2 clinical trials. Giving it in other settings like recurrent disease or in the upfront setting, those were all negative trials. But I think that in my experience, a HIPEC is generally well tolerated. It adds about 3 hours of surgical time, but I think the benefit is profound enough to make it worth it. I think that's really where the role of IP, intraperitoneal chemotherapy, has ended up going. I'm not familiar with many GYN oncologists, at least in New York City, that are still giving traditional IP chemotherapy. In a lot of ways, we've shifted to giving HIPEC.
Thank you. And so we only have time, it looks like, for one more question. So I just want to conclude with, what is your biggest takeaway for patients out of all of this information that you presented today and these latest updates?
I think that these are all really exciting results. I think that the two trials that I presented with the ADCs are exceptionally important. It's the platinum-resistant disease that we're constantly hoping for more options. And I think that these fairly well-tolerated new therapies with really great improvements in progression-free survival and overall survival, I think those are the most exciting of the updates that we got out of SGO this year.
Great. Thank you so much, Dr. Pereira, for this informative program and answering all of these questions. And thank you to all of you who participated today and submitted your questions. Please make sure to check out SHARE's upcoming educational programs and support groups and follow us on social media. We also ask that you please take a moment to complete the survey at the end of the webinar. The survey will show up in your browser when the webinar ends, and the link will also be sent in a follow-up email. All surveys are anonymous, and we really use that feedback to inform our programming and make any improvements that we can. So thank you for taking that. And that concludes today's webinar. Thank you again, everyone. And thank you again, Dr. Pereira.
My pleasure. Thanks so much for having me. Have a great day, everybody.
You too.